So LUMINIZE is actually a study in relapsed refractory classical Hodgkin's lymphoma. This study actually explores, so this study had two parts. One part was run-in phase, where we enrolled 24 patients at 4 different cohorts. In that, we had 2 different dose levels for Acimtamig, which is a bispecific antibody, with AlloNK, which is an allogenic, over-the-shelf, unmodified NK cells, and we had 2 different doses of those NK cells with the interleukin combination. So run-in phase explore 4 different cohorts, and ultimate goal was to have 2 of them dosage selected and randomized against each other in kind of stage 2 portion. We presented data of run-in phase at EHA. Yes, so study design was actually a phase 2, but as I was mentioning that there is a run-in phase which we're exploring 4 different cohorts, 2 dose level of the Acimtamig as well as AlloNK. The study enrolled patients who are relapsed or refractory classical Hodgkin's lymphoma. Out of those 24 patients, most of them, nearly all of them, they were exposed to brentuximab vedotin as well as a PD-1 inhibitor. All of them, they were refractory to PD-1 inhibitor. Majority of them, they were also refractory to brentuximab vedotin. All of these patients also received in past multi-agent chemotherapy. So essentially, these patients had very limited treatment options coming on the study. Now, Acimtamig already has a prior data as a single agent with a modest response rate, which was published years and years back. At that time, the theory was that as it is a bispecific antibody targeting CD30 as well as CD16A, which is expressed in the NK cells, the patients who have been treated with multi-agent chemotherapy, they may not have optimal functions of the NK cells. And therefore, the study was designed based on a phase 1 study, which was also published combining Acimtamig with AlloNK. So that was kind of the basis. But these patients were quite relapsed refractory to standard of care chemotherapy as well as brentuximab vedotin and PD-1. And this patient had very limited treatment options coming on the study. So the primary endpoint of the study was overall response rate as well as safety and tolerability. So we explored that this combination was safe, and there were patients with infusion-related reactions as well as a CRS. There was 1 grade 3 CRS event, but that patient also had cytomegalovirus infection, so there was quite a bit overlap. But most of the patient had grade 1 or 2 CRS, which was managed with the standard of care supportive care. Overall response rate with this combination was 88% and a complete response rate of 58%, which is very impressive in this relapsed refractory classical Hodgkin's lymphoma patients. Also, the estimate of 6-month progression-free survival was 61%. So imagine that these patients were relapsed and refractory to standard of care chemotherapy as well as CD30-directed, brentuximab vedotin as well as PD-1 inhibitor. They had very limited treatment options, and having such a high overall response rate as well as complete response rate with almost more than half patients staying in remission at 6 months is very helpful and beneficial for the classical Hodgkin lymphoma patients. So this is a big significant step forwards for patients with relapsed refractory Hodgkin's lymphoma. So remember that Hodgkin's lymphoma treatment has evolved quite a bit over a period of time. We had ABVD, which was a very standard treatment, and then we had the brentuximab coming in, which is a CD30 directed antibody drug conjugate when combined with ABD, which showed actually survival benefit when they compared it to ABVD. But then SWOG 1826 came in, which actually combined Nivo with ABD in a frontline setting. So what is happening with this change in the standard of care treatment with classical Hodgkin's lymphoma is that most of these patients are now exposed to multi-agent chemotherapy, brentuximab vedotin, and classical of PD-1 inhibitor. All of this, if they fail all of this, which are small portion of patients, their treatment options are very, very limited. And this is a robust and a good combination And there are many benefits to this combination. One, again, it is very active, as we discussed in this abstract, in relapsed refractory Hodgkin's lymphoma patient. Two, this can be done outpatient. None of the patients were admitted in the hospital. Three, all of this treatment, unlike CAR T, where there is a lag that this T cells have to be prepared, all of this are available over the shelf, right? So the patients can get it right away. And the toxicity was manageable. It was not very high, at the cost. So typically, when I look at this kind of combination, I make sure that the benefit patients are getting, it is not at the cost of toxicity, which was not the case. So there are multiple benefits of this combination for relapsed refractory classical Hodgkin lymphoma patients.